morning, ladies and gentlemen. I'm really happy with you to talk about a very exciting topic. Marcel, who is my co-worker, so he has a more easier situation. First of all, because he is a pathologist. So for him, it's very easy to talk about the seed, which is the leading place of metastasis, to talk about lymph nodes. And we heard a very elegant presentation about the pathways of the circulation tumor cells. However, I will touch another question if we talk about lymph nodes. And in the roundtable, we try to make a consensus. What will we do with intramammary lymph node? What we know about it and what its significance is. I would like to show you some history because it's really a very major story, more than 40 years old. As you can see, that Egan and Sweeney was the first in 1982 when they described the definition of IMLN, which is a lymph node surrounded by breast parenchyma. They found roughly 30% when they examined about 160 patients who had mastectomy. That time, mastectomy was the leading form of the breast surgery. As we know, the real diagnosis came from the hand of pathologists. So for this reason, biopsy is so important. And the biopsy of IML sentinel lymph node was described in 1999 by Rule. And it was also a study when 12% of the patient had positive nodes in the lymph node, sentinel lymph nodes examination. We're thinking, where is the location of intramammary lymph nodes? Can be located absolutely anywhere. Doesn't matter if you're talking about an upper and lower or a lateral or a medial quadrant, but it's true that most of them are recognized in the upper outer quadrant. The range is wide because it's between 38 and 72. And again, which is the most imaging? How can we detect these intramammary lymph nodes? And I will ask, of course, the surgeon if I can palpate the intramammary lymph nodes and if it's non-palpable. What's the difference if you're talking about the prognosis? And the question again to radiologists, which is the best examination to detect these lymph nodes? We know that by mammogram, it's a well circumscribed and oval or has a round density. And the size is extremely important because much be smaller than 1 centimeter and must have a central lucent hilum. And then again, the question, in a normal mammogram, should we focusing on IMLN, and what about the role of this information? It was a study by Nant from 1991 and 2005, and they found that 75% of patients with IMLN metastasis had axillary nodal metastasis. It's coming again the question, who has risk with negative axillary sentinel lymph nodes and positive IMLN? And here is the message from Trupis, who said, according to review research, there is no consensus in the case that intramammary sentinel node is positive, but axillary sentinel node is not involved. Very exciting question. What can a physician do? Go and read the material, which is the basic material, the HHCC, the 7th edition, because I would think I will find a correct definition and suggestion, what can I do? But look at, there is very small information about it. It's not enough for a physician. The only message, which is a very critical message, that intramammary lymph nodes within the breast. These are considering axillary lymph nodes for purposes of N categorization and staging. So hop. If I have a patient with a positive IMLN, I have to give an N1 category. The question, is it good for my patient or not? And how can I create subgroups? Very important questions. If we compare the 7th edition to the 8th edition, we have to declare that reviewing the 7th edition, there is no reference to the intramammary lymph node, unlike in the 8th edition in 2010. We've learned a lot about supraclavicular, infraclavicular, internal mammarian lymph nodes, but about if the patient has micrometastasis, but no more information about intramammary lymph nodes. It's very interesting. What about the next step? When I prepare myself for this presentation, I wanted to find very robust literature, but it was impossible. So for this reason, I've seen the CEEAO database. And if you can see the CEEAO database and focusing on the 1A situation, you see the number is much higher in the 7th edition compared to the 8th edition. So there is downstaging. And again, if we are focusing on 1B situation, there is a percentage of the patient. Please compare to the 7th edition. This number is much, much higher. So the question is, who need more treatment if our patient who in the past have had just in the 1B situation? And follow up, the thinking jump to the 2A, look at this number, and again the number in the 8th edition, which is much lower. So there is a downstaging in the new version. And the next step is the 2B, look at this number, and look at the other. It could be the same, so we could say that this situation don't generate for us more problem. And jump to the end of this slide, the 3B, it's a very slow number, and the double, the higher number in the new edition. And the 3C situation, it's a small number and a double higher number in the new edition. It was very interesting for me, and it's another distinct between the two editions. And you can see again that in the 3C and the 3B, there is a huge difference between the 3-year overall survival. It's important. And again, in 1A and 1B, no difference between the 3-year survival. So we can do something with this patient, and we can thinking in the further classification if we make in the multidisciplinary team the correct decision what will be happened with our patient. And it was found, and very interesting, PhD work from Africa. And look at these columns are the similar. Here is a downstage in a 1A, and an upstage in 1B, and again a downstage in 2A and a 2B and the 3A, but the 3B and the 3C has more reflection in the future. And again, if we see the African population, they divided into the upstaged group and downstaged group. The 3A and 3B, there is a high downstage situation. and there is a huge and extremely large number. So that's the reason why intramammary lymph nodes metastasis is the topic of this morning. I'm just a medical oncologist, so I'm not very happy, but I have to touch the question of the radiologist situation and the pathologist situation too. Despite that, Marcel have had a very elegant presentation. I will show you the situation with IMLM. I was very curious to see a slide from you, and of course, I will have several questions toward you, so be sure. How does the pathologist see the difference between the two editions? And look at again, from the 7th to 8th edition, 66% of stage 2 patients migrated, majority to stage 1, and a small amount to stage 3. And again, 36% of the stage 3 patients migrated to the other stages, 22% to stage 1 and 13% to stage 2. I will not explore the role of the gene set enrichment analysis, and of course, I do not want too much about the mutant allele tumor heterogeneity, but it's an important message if MET-H and the HRD, they too were elevated in a higher stage in the new edition, and I think it's hold a very important information for us. And again, what about the T-cell exhaustion markers, the PD-1 and PDL1? They were all found to be elevated in higher stage in the 8th edition, but not in the 7th editions. So we've done something wrong in the past. I don't know. It's an important, again, to touch this question and to make a discussion during the roundtable session. And the message from the pathological review that in the 8th edition, the breast cancer staging system categorizes cancer by aggressive biology better than in the 7th edition. And it was found that higher stage tumor trigger an enhanced immune system response, but are unable to overcome the aggressive cancer biology. And here is the question to the radiologist. So this new edition really focusing on imaging and on the biological feature of the tumor. But through anatomical staging of the breast cancer, the basic is the mammogram and ultrasound, and if required, the MRI examination as well. And it's a new one that the new staging integrated the biomarker data. Imaging has significant role. Otherwise, the message from this chapter is it is still not precisely determined which radiological examination is the most accurate for identifying the IML. Again, an interesting question. And I'm not a radiologist, so I will not detail this slide, but here are two very critical issues: which node is benign and which node could be pathologist, the size, the feature, the node characteristic, the density, they are extremely important, and well-trained radiologists are needed to give us the correct diagnosis. So from the radiology, it was an interesting synthesis that before IMLS were included in the breast cancer staging system, they didn't specifically affect to the lymph node status categorization. If only the IMLM were found, without any involvement of the auxiliary status, the patient might have been considered node negative. It's important, we have to discuss it because has a following decision, and the patient could have an over-treatment or an under-treatment as well. And those nodes were often overlooked or not specifically addressed in early and staging system. And here is an algorithm. The question is toward the surgeon. I will not detail because that's the specific situation when the patient had or not had auxiliary metastasis. As Marcel mentioned before, it was really, they had excellent slides about it. And what about the situation when the patient had a positive IMLN and a negative auxiliary status, or both are positive? What about the consequence? And it was very interesting because they found when IMLN included into the staging correlated with both overall survival and relapse-free survival as well, compared to the other situation when there was no correlation. Important, interesting, and questionable. And the other message from this study, it was performed an analysis and found that the patient with stage 3 disease, when they involved the IML, and had a much, much higher, roughly 9 times risk of developing local or distant recurrence, and roughly 9 times risk of dying due to disease in the patient group of stage 2. So the definition of risk is really very important, and as I am a medical oncologist, the next slide is more easier for me because that's my field. Everybody know the prognosis of the patient, which represented by these curves, and the sloping of the curves are very similar. The only distinct is the pathological background, if the patient has an HR positive or hormone receptor negative, HER2 positive, HER2 negative, or triple negative, but the tendency is the same. Is it change if we involve intramammary lymph nodes into the prognosis? Nobody knows. It would be nice to create a prospective study to collect the data. Maybe we will have a little bit another sloping of this curve. And look at these two curves. Here are the stage 2, here are the stage 3 patient. What about the new classification? They are old data, nobody knows. And again, very, very, very old studies. Here is the role of the lymph nodes, and look at these two curves. If we involved IMLN and some percent of the patient will enroll in this group, will be changed in this distinct. And again, if we see the age and the T status and the estrogen receptor expression, which is the stronger, it will be the question toward the pathologist. And the next, if we see the Ki67 expression, Marcel showed you Professor Kulka's picture, and Janina said, so pathologist is the risk factor if we're talking about Ki67 index, because if the pathologist is well-trained, I will grab in my hand an excellent result. If the pathologist not, look at why is it so important. Small percentage difference create a totally other sloping of the curves. And again, we have a lot of prognostic and predictive tests to have better knowledge to make a correct decision about the patient treatment. What will be happen if the recurrence score-based curves will change using this new classification? I don't know. And look at the oncotype. The oncotype, we divided the patient into two groups, premenopausal and postmenopausal. And in the premenopausal group, if the patient will roll into the N1 situation, this column wall going to the left side. It's important because it means that more patient must have treated with chemotherapy. Is it true or not? We have to talk about it in the later period. And again, about the risk category using the PAPI index. And everybody knows that the best situation, if I touch the relapse-free situation, is the green curve, the group 1. But what about the PAPI index? You will see it include the node status, negative or positive, the patient with just one IMLN with negative auxiliary status. Really? And one patient? I don't know. It's a very nice study when the patient in a hormone positive, HER2 negative breast can got a short endocrine treatment, and then after the surgery, they divided using by recurrence score into 2 groups. And again, here is the N0 and N1 situation. My question will be toward the pathologist. Again, the role of Ki-67, and what about the threshold? The threshold will be 10% or will be changed it? I don't know. But here is the results, and one new factor, the age, because that is the total patient population. Here is the very young patient below 40 years. Here is the postmenopausal population. Like a Caesar, there is a big alteration between the 2 curves. And again, a middle group when there is some difference between 2. But what about the role of lymph node status? So if you're talking about this patient group, the tumor size, nodal status, and grade impact, recurrence risk, and improved prognostic accuracy of gene expression signature. And it's a new slide from the ASCO from this year in June. I like the real life data because they hold more population. So everybody knows that in a clinical trial, we're working with sterile patient who had just one problem, but probably no comorbidity. But in the real life, majority of the patient suffering from several other diseases. And again, if we're focusing on end status and just focusing on distal metastasis, you see the N1 situation and the N0 situation. There is a completely other sloping of the curves. What will be happen if we make a new classification of this patient group? And it's just a slide for our pathologist. Based on the new MemPrint PAM50 examination, we totally confused because in the hormone receptor positive tumor, if they test enroll the patient into the high 2 groups, the patient will have immunotherapy, but they test or using the nodal status. So here are my 2 last slides, and here are the questions. What is the correct staging? Does the IMLN behave differently in palpable versus non-palpable cases? How should we evaluate a positive IMLN in the sentinel is negative? What does the expression of estrogen receptor or the Ki-67 index add? Is there a needed MemPrint or PAM50 for better risk group estimation? Probably yes. It's a question to the insurance, and I do not want to touch this field. A correct role of the radiotherapy. Over-treatment must be avoided, and under-treatment also must be avoided. And borderline cases, what to do in case of migration from N0 to N1, and the question is the same. what we'll do in case of migration from N1 to N2. And it's an old need, an unmet need, risk assessment issues in ER positive, HER2 negative patient group. And of course, what about the triple negative breast cancer group characterized by MMPrint or PEM50? And that's my last slide. So I'd like to say that it is worth considering prospective studies, and today gives us the opportunity to think about this together, initiate international data collection, and jointly reach a consensus and a publication. Thank you for your attention.